Good evening, everyone. This is V.K.Kapoor from Mahatma Gandhi Medical College and Hospital in Jaipur. Welcome to the 18th Masterclass of the Jaipur Surgical Tutorial. Jaipur Surgical Tutorial, or JST as we fondly call it, is an online education portal that we started more than 3 years ago when I moved from SGPGI Lucknow to Mahatma Gandhi Hospital in Jaipur. The JST is being managed by Dr. Anand Nagar, my colleague in the Department of HPB Surgery and Liver Transplant at the Mahatma Gandhi Medical College and Hospital in Jaipur. Those of you who are new to the masterclass and are not members of the JST, you can send me a message and I will add you to the JST group, and then you will start receiving information about the JST. Jaipur Surgical Tutorial conducts an online class every Saturday, 9 to 10 a.m. India time, where students, mainly MCH and DNB surgical gastroenterology and HPB students, they present cases which are then moderated and discussed by faculty, including myself. The students sometimes also prepare operative surgery sessions where they discuss indications, preparation, procedure, and complications. Again, these sessions are moderated by the faculty. Once in a while, we have faculty lectures also on some topics. We also cover non-surgical topics like anesthesia, critical care, radiology, pathology, radiotherapy, and other disciplines. This session, as I said, is every Saturday, 9 to 10 a.m. India time. In addition, we also conduct these master classes, which are held every last Wednesday and Thursday of the month, 7 p.m. to 9 p.m. India time again. And as I mentioned, this is the 18th masterclass. We have already conducted 17 masterclasses. In addition, we do an annual CME program, which we call Jaipur Surgical Festival. 4 Jaipur Surgical Festivals have already been held, and the 5th one will be held in the month of December, the first weekend, Friday, Saturday, and Sunday. The theme for the 5th Jaipur Surgical Festival will be Surgical, Radiological, and Endoscopic Anatomy. All the previous more than 200 classes of JST, all the previous 17 JST master classes, and all the 4 Jaipur Surgical Festival, all proceedings have been video recorded, and they have been put on the YouTube channel of Gastro University, which is a brainchild of my former fellow and now a consultant GI surgeon in Ahmedabad, Dr. Avinash Tak. And his team, including Himanshi and Pinesh, offer all the technical help. They conduct these sessions by generating Zoom links, by streaming these sessions live, and by uploading the videos on the Gastro University YouTube channel. Unfortunately, for this masterclass, I am not in India. I am actually in Nepal for conducting an exam and for delivering some lectures. So I am not able to join with my video, and I may not be able to attend the session, but I'm very happy that one of the senior surgical colleagues, Dr. Angelina, who was the professor of surgery at the Puducherry Institute of Medical Sciences in Puducherry, accepted my request and invitation to moderate this masterclass, to design the masterclass and get the faculty for this masterclass. I am grateful to all the panelists, including Dr. Preksha, Dr. Joses, Dr. Niladri, and Dr. Vignesh, for accepting my request through Dr. Angelina to be the faculty on this masterclass. Also joined online is my younger faculty colleague in trauma surgery department at my hospital, Dr. Avinish Katiyar. And I would request Dr. Angelina to kindly give an opportunity to Avinish also to chip in during the panel discussion and the open house session. So with that, I would like to hand over the session to Dr. Angelina to introduce the speakers and the topic and continue with the masterclass. Dr. Angelina, please. Yes.
For
yes,
having the trust in me. And I thank all the participants for having come on board. And I welcome Dr. Katya. Please chip in with your inputs. And let's start the session right away. We have this session on trauma to the abdomen. And we have got some sessions lined up on 2 days, that is 29th and 30th. And my colleagues have kindly consented to present these topics. Now, it will not only be the textbook that they are talking about, they will be bringing their personal insight into all these sessions. So, the first session will be on evaluation of the traumatized abdomen or evaluation of the trauma to the abdomen. It will be by Dr. Joseph. He's an assistant professor in CMC Vellore. He had done his MCH from PIMS, New Delhi, and he has researches including trauma coagulopathy, trauma registry, and he has developed his own indigenous first responder course to the lay public. Over to you, Dr. Joseph.
Thank you so much, ma'am. First of all, thank you so much to the Jaipur Surgical Tutorial, Dr. V.K.Kapoor and Dr. Angeline for having me here today and allowing me to open the innings, so to say, on this masterclass on trauma abdomen over the course of today and tomorrow. So I am Dr. Joseph. I'm an assistant professor in the Department of Trauma Surgery, and I will be taking you in the next 15 to 20 minutes on how to evaluate the trauma abdomen. So the next 15-20 minutes is going to be actually very basic, very simple. It'll get even more complicated once we go into individual injuries. But my job is actually to tell you what to do when you are faced with a patient with abdominal trauma in the emergency department or wherever it may be. So over the course of the next 20 minutes, we'll try to see how to approach a patient with abdominal trauma, learn the ATLS way, which most of us probably already know, understand why it is important to know the physiology and why it is important to correct the physiology. Identify injuries at the bedside using some adjuncts and understand the importance of kinematics, and also touch upon why imaging is so important in this day and age in identifying abdominal injuries. So we'll start off with the case scenario. This is a patient who came to us about a month or so back. He was a 24-year-old bicycle rider hit by a four-wheeler. He came to us 2 hours after his injury. While we did a primary survey, we found that he was tachycardic, he was hypotensive, and when we did a fast, we found that the fast was positive in almost 3 quadrants in the abdomen. Now, in this very simple scenario, what we can actually see is that the physiology is grossly abnormal, the cause for which is possibly a bleeding within the abdominal cavity. So the term physiology here is very, very important. So because the physiology is deranged, that is what is going to probably give a poor outcome to this patient in the next few hours. And I'm not sure if William Halsted actually said this verbatim, but he was one of the pioneers who brought in the concept that it is not just important to be an anatomically oriented surgeon. It is not just important to know your anatomy, have your surgical skills, improve your surgical acumen, but it is only when you integrate this by knowing what the actual physiology of the patient is concurrently, that is when you can have a good outcome for your patient. And there is probably no other specialty where understanding the physiology is as important as in trauma care. And for patients who are injured in the first few hours, you can call it the golden hour, you can call it what you want. But in the first few hours, if you are able to control the cause, why the physiology is abnormal, simultaneously correcting the abnormality in the physiology, you are guaranteed to have a good outcome. Now, the question is, how do we correct this physiology? And for that, we have to thank these two gentlemen. This is James Steiner and Mr. Paul Collicott, who came up with this systematic methodology of evaluating a trauma patient, which we all know and which we all train in today, called the Advanced Trauma Life Support. This is actually the first manual, the first flyer of the first course, which was done in 1978, where they introduced the concept of ABCDE, which, like a nursery rhyme, has been repeated time and again over the past 30 odd years and has actually stood the test of time successfully. So we all know that in a patient who presents to us, whether it is with head trauma, whether it's with chest trauma, whether it's abdominal trauma, it does not matter. We will always follow the ABCDE dictum, which is airway with cervical spine stabilization first, followed by breathing and ventilation, circulation with hemorrhage control, followed by disability evaluation, and then finally preventing hypothermia and preventing exposure. So if you're working alone in a center with yourself and a few other colleagues alone, you will probably do this in a vertical manner. But most of us work in hospitals with an emergency department with multiple people in a team, and we would be doing what is called as the horizontal resuscitation, pretty much similar to how an F1 car tire is probably changed. So it is quick, it is fast, but at the same time, the principles are constant. So primary survey or ABCDE, we will use a certain number of adjuncts, your non-invasive monitors to check the vitals, saturation. If you have the facility for it, we'll do a blood gas. Sometimes we'll put in an nasogastric tube, urinary catheter. We'll use certain imaging technologies like chest X-ray, pelvic X-ray, and perform an EFAST at times. So once you've done all this, you've simultaneously resuscitated the patient, you will re-evaluate, and then only you will move on to performing a secondary survey. It is important to note that no matter what the injury or the site of injury, no secondary survey is done till the ABCs are stabilized. Once the secondary survey is done, there are certain adjuncts of secondary survey like a CT scan, MRI, or some other special studies, perhaps something like a retrograde ureterogram. You would do all of that, re-evaluate the patient, understand or summate what are the injuries which need care, and then decide on a definitive care plan. So again, I go back to what we are doing essentially in the primary survey is correcting the physiological derangement. And once the physiology is corrected and the secondary survey is done, then we would make a plan as to what to do or how to approach and how to repair the anatomical derangements. So going back to our initial patient, he came in with a heart rate of 140, BP of 70/40. He received that initial 1 liter warm crystalloid infusion, and then the heart rate came down to 110. The blood pressure picked up to 94/60 millimeters of mercury. But the blood gas, which was initially 7 lactate, base deficit of 12, has gone up to 10 lactate and base deficit of 19. Now, the question is, it's kind of a mixed picture. If you look at the vitals alone, it seems like he's improving. But if you look at the gas, it's actually worsening. The question to everybody is, what is the class of the shock? And is he actually improving or is he deteriorating? Again, ATLS has the answer. It has given us a classification of shock based on the amount of blood loss. I'm not going into the details of this table. We are all aware about it. Most of it is not numerically quoted. The estimation of blood loss is, but heart rate, blood pressure, it just gives you arrows to tell you it's either coming down, it's normal, or it is going up. The only variable which actually has value in this is the base deficit, which has made its way in the 10th edition of the ATLS. And it actually gives you specific frequencies beyond which you can categorize patients into class 1, class 2, class 3, and class 4 shock. Now, in our patient, after the initial fluid resuscitation, you can note that there is a response in the vital signs. But at the same time, his gas has probably not improved. In fact, it has deteriorated. So ATLS gives us this classification of response to initial fluid resuscitation as a rapid response, a transient response, and a minimal or no response. What this actually means is, if there is an initial blood loss, which has sealed off or which has clotted off initially, and you've replaced that loss, the patient's vitals will most likely come back to normal. If there is an ongoing blood loss, which is not tamponaded fully, and you have corrected the blood loss, which is ongoing, there may be a transient improvement. That is when you call it as a transient response. These patients, the moment you stop correcting, their vital signs will dip again. It is like pouring water into a bucket with a small or relatively medium-sized hole at the bottom. Minimal or no response is actually very bad. That usually means there is a high volume loss ongoing, and no matter what amount of replacement you give simultaneously, there is probably not much improvement. And these two categories of patients have a very, very high need for operative intervention. So in our patient, most likely he would fall into the transient responder category because his vitals are improving, but at the same time, there is probably an ongoing blood loss, which is characterized by a worsening base deficit. And he most likely will need an operative intervention because if you remember, he had a positive FAST in 3 quadrants in the abdomen. So let's ignore that patient and let's say that our patient is a non-responder. The dictum in ATLS is that a non-responder should go to the OR. Most of the times when we worked in the emergency department, our emergency medicine colleagues would often tell us that, this patient is not responding. We've given the initial fluid challenge. Sometimes if blood is available, give them the first pint of blood as well. And the BP is just not picking up. The patient is severely tachycardic. Please shift this patient to the theater. The question is, yes, that is the correct thing to do. But to do what? What are we supposed to do in theater? Which cavity are we supposed to explore? What area are we supposed to intervene in? And what is the procedure which we are supposed to do? That is what we need to find out or determine before we actually shift this patient to theater. All this is part of the initial 10-minute primary survey, which we are supposed to do. So thanks to Bailey and Love, we know this wonderful dictum of blood on the floor and 4 more. Again, something which has stood the test of time. All we need to do, if there is ongoing blood loss, look for external signs of bleeding, external sources of bleeding, and then look at these cavities which can hold a large volume of blood. Most commonly the abdomen, the thorax, pelvis and retroperitoneum, and the long bones, specifically the femur in the thighs. Because we are talking about abdominal trauma today, we'll focus on how to evaluate if there is ongoing blood loss within the abdominal cavity. So clinical examination is very, very important. Normally, when we are examining a surgical patient, we do inspection, palpation, percussion. ATLF tells us the same thing in a different way. It tells you to look, listen, and feel. When it comes to abdomen examination, there is probably not much to listen to, but it is very, very important where you look and how you feel. So most important thing is to look for any obvious external source of bleeding, usually seen with penetrating trauma. The other important thing to look at is abdominal distension. Usually, rapidly filling blood within the peritoneal cavity is quick to cause abdominal distension. And this might probably be one of the first initial signs that would tell you that, the amount of blood which is lost is quite large. You need to also look at the pelvis, see if there is any obvious bruising, which could indirectly tell you that there is probably a pelvic fracture. You need to palpate the abdomen. It is not often that in the very beginning you will get abdominal signs. In fact, hemoperitoneum may not even have any abdominal signs other than abdominal distension. But if there is a bowel perforation, if the patient has come in a delayed manner, you might still get abdominal signs. A pelvic compression diffraction test is a little bit controversial. It basically tells you if the pelvis is unstable, is there a possible pelvic fracture which is there. It is controversial because when people advocate for it, many people perform the test on the same patient again and again. That is what needs to be avoided. It can be done by the initial examining person single time. If it is positive, you need to treat for it. So what is the treatment? Treatment is simultaneous. We have to remember that ATLS, in ATLS, you have to diagnose and treat simultaneously. The goal is to bring back the physiology as early as possible. 2 wide bore cannulas, take samples for grouping, typing, cross-matching, get a gas in hand, send a full blood panel, start your initial warm crystalloid infusion. If you've got blood, start that instead. If the pelvic compression test is positive, place a pelvic binder quickly. And if the patient has come to you within the first 3 hours, give him a bolus of tranexamic acid. Now, beyond clinical examination, is there any other way that we can look into the abdomen and determine if there is ongoing bleeding? Earlier, we used to do diagnostic peritoneal lavage. Some people advocate for diagnostic peritoneal aspiration. But beyond all of that, there are much, much better tools which we have in hand. Our goal is to make sure that the patient who's so unstable and who's so sick, who's probably having an ongoing blood loss in the abdomen, doesn't have to go anywhere. So the radiology has to come to the patient, and we only need 2 very simple things, which is an ultrasound machine and a portable X-ray. Ultrasound machine to do an extended fast exam, and a portable X-ray machine to look at the chest and the pelvis. We don't need an emergency medicine physician in hand. We don't need an anesthesiologist. We don't need a radiologist. EFAST is a very, very simple procedure to perform. It takes about 2 to 3 minutes in an expert hand. And it has been proven time and again that fast exam by surgeons and even by emergency medicine physicians are as good in picking up findings as with radiologists. It's a very simple 4-window view for the routine FAST, and the extended FAST, of course, looks for pleural and thoracic abnormalities as well. So I don't want to go into the details of performing FAST, which is probably beyond the scope of this lecture, but this is an essential skill which all of us as surgeons, especially those who are in training in their postgraduate phase, should be comfortable performing at the end of their training. But you've done a FAST, you've performed it, you've picked up fluid, or sometimes you've not picked up fluid. Is there any other place in the abdomen where blood can get collected and you cannot see it? And that is the retroperitoneum. This is something which is most commonly missed after trauma because there is no direct way in the bedside to pick up retroperitoneal injury. like a fast. It's very difficult because of the overlying bowel gas. It's very difficult to pick up retroperitoneal bleeding. People have tried, but the sensitivity and specificity of that is not very, very high. But there is an indirect way. The most common cause for retroperitoneal bleeding is a pelvic fracture. So if we can get a portable X-ray of the pelvis, this is a patient we had about last week, where we had a positive pelvic compression test. We put in a binder and then we got in a portable X-ray. You can see that there are superior inferior pubic rami fractures on both sides. If you look at the right SI joint, it is widened in spite of the binder being in place. So this patient probably has a pelvic fracture resulting in pelvic retroperitoneal bleeding, and that was the reason why he was unstable. So if you correlate this pelvic fracture with the vascular distribution in the pelvis, it's very easy to understand the number of vessels which are there, especially the branches of the internal iliac artery and the pre-prostatic plexus of veins, all of which can be very easily ruptured in bad pelvic fractures. And this blood will get collected in the pelvic peritoneum, and it has a fast track entry into the entire retroperitoneal space, moving from zone 3 to zone 2 and even zone 1. So retroperitoneum can carry almost as much as the amount of volume the intra-abdominal cavity can carry. And if a patient is there in whom all of the other areas are negative, very, very, very strong suspicion of a pelvic fracture, please use a pelvic X-ray to confirm, because it is not always that a pelvic compression test may be positive. Pelvic bruising may not always be present. The patient may be obtunded and may not give you a positive sign on performing a pelvic exam. So always try to get a pelvic X-ray when you do not know where else the patient is bleeding from. What about some other adjuncts that we commonly use in primary survey? Gas we have already spoken about. If you are thinking only about a circulatory problem, if the problem is only shock, a venous gas is more than enough. The initial sample which you collect can be analyzed for a venous gas, and it will give you the base deficit and the lactate values and the amount of acidosis which is there. A nasogastric tube in the abdomen, sometimes it can aspirate blood. This is commonly seen in patients with maxillofacial trauma. Aspirated blood is the most common reason why you would get blood in the NG tube, but rarely it could be an indirect sign of an injury to the stomach. Blood in the urinary catheter, very, very common, especially associated with pelvic fractures. It could be indirectly suggestive of an upper or a lower genitourinary tract injury. Upper usually is renal, and lower most commonly is bladder injuries associated with pelvic fractures. Rarely you might get an ICD which is stained with bile, which could be an indirect marker telling you that there is a diaphragmatic injury or there is probably an esophageal. So now that we've done our initial assessment, we've determined what the source of bleeding is. Our goal is to identify that source, achieve hemorrhage control, and fill up the patient. So whatever is lost has to be replaced, and ongoing loss has to be stopped. And with that, if we correct the physiology, our initial assessment is complete, and we can then move on to a detailed secondary survey. Now, once we finish our initial assessment or our primary survey, before moving on to secondary survey, we commonly take what is known as the ample history. This is probably the time, if somebody has not already done it in your team, you would go in and take a little bit of a detailed history. What was the exact mechanism? How did the injury occur, etc., etc. Now, does that have any bearing? Having that knowledge, can it give you any advantage in probably thinking of what injuries could possibly be there in a patient? This is particularly more important in the pre-hospital setting, but it also has a lot of value in the in-hospital setting as well. So I don't want to bore you with the details of the technical terminologies, but strain is the most common cause of injuries anywhere in the body. There are different types of it. Tensile strain is commonly what causes long bone fractures, less commonly seen in the abdomen. In the abdomen, these three are the most common, which we see. The first one is shear strain. Shear strain is nothing but when an organ is tethered at any point and there is a sudden deceleration, because it is fixed at one point, the other end, which is freely floating, gets stretched and it gets torn. Very classically, you see this with deceleration injuries causing hilar injuries of the spleen, commonly causing bucket handle injuries of the mesentery. This should especially be suspected when there is a history of sudden deceleration, which is high velocity two-wheeler, four-wheeler injuries, fall from heights, especially higher, larger heights. The other common type of strain is a compression strain, classically causing injury to the pancreas, where the history would be classical such as a steering wheel injury directly to the epigastrium. Sometimes in young children, you might get a history of handlebar injury to the abdomen. All of these causes a sudden compression, compressing the pancreas between the object and the vertebral body behind, causing injury. All of this will be spoken about probably in the individual injuries as well. And the other classical injury mechanism which we see in the abdomen is the overdistension injury, which is commonly seen with hollow viscous organs. Most of the time, when the bowel is distended and there is a sudden increase in intra-abdominal pressure, that will cause it to pop like a balloon. And usually it results in injuries in the antimesenteric border of the bowel, and more commonly in patients with filled up bladder, causing bladder injuries. So if we know the mechanism, if we know what type of, is it a fall, is it a sudden deceleration injury, was there direct impact to the abdomen, we can probably predict what injuries to suspect, and we can actually look for these injuries when we are looking at the imaging, which I'll come to next. Now, what I talked about right now is the blunt mechanism. All of this goes for a toss if it is a penetrating mechanism. Then it depends on whether it is high or a low velocity. Is it a stab or a gunshot? What is the angle of impact? What type of object was used? And which vessels or which organs it went through? So the kinematics is completely different if it is a penetrating trauma. But the dictum is, if you have a patient who's presented you with a penetrating injury to the abdomen, looking at the site where the injury has entered or exited, it is easy for us to trace the trajectory. And even if the patient is stable or unstable, if you're going with this patient to theater, or if we are evaluating the injuries using advanced imaging, it is always important to trace the trajectory of the injury. So I just want to flip the initial case scenario where the same patient has come to us after 12 hours of injury. Now this patient's primary survey is normal. He's hemodynamically stable. He's fast positive in just a single quadrant. So this patient, your primary survey is normal. He's had his initial resuscitation. He's stable. What do you do next? You would do a complete secondary survey, which is a head-to-toe examination, and then use certain adjuncts of secondary survey. And the most common adjunct which we would use is a simple contrast-enhanced CT scan of the abdomen. Now, CECT is one of the most commonly used technologies and the most important tool in our disposal to identify all injuries in patients with abdominal, or the term I would like to use is torso trauma. So most of our patients are not unstable. Majority of the patients that come to our emergency department with torso trauma are relatively stable. And depending on the indication for it, majority of them would probably need some kind of advanced imaging. In my opinion, and a lot of my colleagues will also agree with me, I hope, it is very important for surgeons in this day and age to be able to read their own CTs. And a lot of them do that as well in their own particular specialty. Because what happens in many colleges and many hospitals is, after hours, the amount of patient load is a lot. Contrast scans, getting a contrast scan done is tricky. Technicians are probably not there. There is a single radiologist who has to interpret emergency radiology, trauma CTs, ultrasound. So it becomes too taxing for one person to do all of this. But to make a plan, to understand what the injuries are, surgeons can do all of this. So we had actually written this small, simple review article where we extrapolated the DRS ABCDE technique of reading a trauma chest X-ray into reading a torso CT. In a systematic way, so that in about 10 to 15 minutes, you can go through a trauma torso CT and at least identify what a potentially life-threatening injury which needs urgent care in form of either an angioembolization or a transfer to another hospital if the facility to take care of that patient is not available at your hospital. Of course, if the patient's injuries are such that you cannot manage this patient in your center, you should not waste your time doing any advanced imaging, and you should probably refer this patient up front. I don't want to touch upon the concept of whole body CT. We call it head to pelvis CT. I don't want to confuse the audience about whether this should be done or not done. The data is contrasting at the moment. What I would say is that currently, if you are working in a public hospital, the volume of patients is very large. The data of using this for every patient is probably not very clear, but we'll probably get there in a few years or so, hopefully. More important than that, something which we commonly see in many institutions or many hospitals, which we would strongly advise against, is that when you are looking at the abdomen, unlike us, trauma doesn't really look at the abdomen as a single region. And the kinetic energy, especially with blunt mechanisms, are transferred to the chest as well. So when it comes to trauma, it should always be a torso imaging which should be done, combining chest as well as abdomen. And it is very important that non-contrast CTs are not done. CT imaging should always be with contrast, because you are looking at possible vascular extravasation, you are looking at vascular injury. So it is always contrast CT which is advised. So in our patient, we've done a CT. There is a grade 3 liver injury. There is some hemoperitoneum, no pneumoperitoneum, no pneumoretroperitoneum. Our patient is hemodynamically stable. What do you do with this patient? So I don't want to go into the management part, which will be covered in the coming lectures, but just a word on what non-operative management is and why and where it should be done. So it is important to understand that although NOM has become the pillar of management for solid organ injury in this day and age, it should only be done in patients with hemodynamic stability. There is no obvious operative indication. There should be diagnostic and interventional facilities available in your institution. There should be facility for intensive monitoring, and expert care 24 hours should be available in the form of surgical, blood bank, anesthesia team. So basically your hospital should have a dedicated trauma team. Now, if all of this is not there, that does not mean that you move from a non-operative management to a surgical management. If the facility is not available and the patient is hemodynamically stable, it is always better to refer this patient to a center where these facilities are available. So just to put everything together, the approach to the abdominal trauma is holistic. Always follow the ATLS way, ABCDE. Liberally use your adjuncts, look at the mechanism, understand the kinematics, use basic and advanced diagnostic radiology, correct the physiology, correct the cause for the derangement in physiology, and you will have a successful outcome. Thank you so much. Happy to take questions now or later. Thank you.
Joseph, I just had a few things to add on, not a query. This talking about physiology to surgeons, especially trauma surgeons, is very, very important. Number one, the physiology in trauma is very global, number one. And number two, it's very dynamic. So it goes hurtling down. In fact, a physiological deterioration is easier to pick up bedside and rather than an anatomical disruption. In fact, physiology moves before the anatomical disruption. Number one, that is picked on imaging. Now, a grade 3 spleen in two different people can have a different response. So, any scoring that involves both physiology and anatomy is much more useful than a scoring which is dependent only on anatomy. So when you have a CT scan report, along with that, fix your physiology that patient is having at that point of time and try to make up your mind. Now, what I wanted to tell regarding the cavities, this is very important. I have seen personally people getting a laparotomy done because there was some very little free fluid on ultrasound, but actually he was having both bones fractured. I know that was splintered, but the main problem was in the bones. This has happened, and it's not as if it cannot happen. So getting a grip on the cavity is important. Not only that, when you see the cavity bleeding, ask yourself, is this bleeding enough to put him in the physiology that he is in now? Otherwise, you'll be opening cavities, and the easiest cavity to open for a general surgeon will be the abdomen. Now, coming to tranexamic acid, very, very game changer. Crash trial, which also involved one of our hospitals from Bombay. It was a global multi-center research, and they have found that tranexamic acid helps a lot, especially where trauma systems are not in a position to take the patient and run into the operating theater immediately to control bleeding. And as far as tranexamic acid is concerned, it's a very safe drug in trauma, and they have found out the incidence of thromboembolism is only 1 in 1,000. So it is recommended by trauma organizations to give tranexamic acid if you feel the patient's vitals are bad because of bleeding, not only abdomen, anywhere else. This is what I wanted to add, Dr. Joseph.
Thank you, ma'am. Completely agree with everything you said.